Hi, and welcome to APP to APP virtual lectures. My name is Lauren Massimo. I'm a nurse practitioner at the University of Pennsylvania in cognitive neurology and an assistant professor in the School of Nursing. And today I'm going to be talking about cognitive presentations of Alzheimer's disease and related dementias. Just a disclaimer, I'm going to be giving a fairly broad overview of dementia, and any medications or treatments that I mention again are going to be described in a broad manner, and as always, you should treat your patients on an individual basis. So the objectives that I'd like to cover today are, first, you're going to talk about how do we differentiate cognitive changes from normal aging. So how do we determine how someone has a pathological conditions such as Alzheimer's disease. We're going to talk about the most common cause of dementia, with again the most common cause being Alzheimer's disease, but we're going to talk about other forms of dementia as well. We're going to talk about how to evaluate different domains of cognition, and then lastly, recommend broad plans of care for older adults with dementia. So to get started, I want to just review the anatomy. Here we're looking at a sagittal view or a side view of the brain. And you all know that the brain is made into two hemispheres, the right and the left hemisphere. Some of you have probably heard that the left and the right hemisphere serve slightly different functions. It's generally accepted that the left hemisphere is involved in more linear reasoning, exact mathematic calculations, and aspects of language, such as vocabulary and grammar. The right side is often thought to be involved in more creative and artistic and nonlinear thinking. There are four lobes of the brain. You can see my pointer here. The frontal lobe is in the front part of the brain. Then we have the temporal lobe here on the side of the brain, the parietal lobe that kind of sits high or up and in towards the back of the brain. And then we have the occipital lobe, which is in the back of the brain. So those are the four lobes that we're going to be talking about because each lobe has a particular function. And when we do a neurological exam, we organize the exam by system, and we perform a series of tests that reflects the function of a particular part of the brain. For example, when we evaluate coordination, we're generally probing the cerebellum. The same idea applies to the cognitive exam. The frontal lobe is really important for problem solving and judgment and personality. The temporal lobe is important in processing speech and language. The middle temporal lobe is really important for memory in a structure called the hippocampus, which we'll talk about is implicated in persons who have Alzheimer's disease. The parietal lobe is important for sensory and visual spatial function, how we make sense of what we see with our eyes. And lastly, the occipital lobe is important for vision. And so this helps us to isolate problem areas. So if someone comes into your office and they're complaining of speech difficulty, you might suspect damage to the temporal lobe. So it's important to know that cognition is not just about memory. It's the mental activities of knowing, thinking, learning, and judging. And it's divided into cognitive domains. So attention, your ability to stay focused on a task. Attention enables you to focus on an item while mentally identifying and distinguishing the non-relevant information. And it's really imperative for encoding information for your memory. Executive function is a higher order cognitive function that involves things like planning and organizing, problem solving, and task switching. Think of making a grocery list, right? We have to go through our pantry and our cabinets. We have to either make a mental list or write down what we're missing, and then we have to execute that action by going to the grocery store and shopping for our food items in an efficient way. Then we have memory, which is divided into long-term and short-term memory. And in Alzheimer's disease, short-term memory is what is typically affected. Language involves listening and comprehension, speaking, reading, and writing. And then we have praxis, or translating an idea into action. So think about wrapping presents. And this ties in closely with visual spatial functioning, perspective of objects in space, perception of spatial relationships. So these are the cognitive domains that we're going to talk about and talk about how we evaluate these cognitive domains. So with aging, there can be mild changes in memory and the rate of information processing, but these are not progressive. So they generally don't get worse over the time. And importantly, they do not affect daily functioning, right? So they're common, but they're not severe enough to interfere with everyday functioning. So some common complaints that we see from older adults, they sometimes misplace objects. They often lose their keys, but oftentimes they'll be able to find them. There's some problems with word finding. There can be slowed intellectual response time, and they can start to have a little bit more difficulty with attention. Dementia is a term that's used to describe a plethora of disorders that have a profound impact on a person's day-to-day functioning. And the most common form is Alzheimer's disease. So I often get asked, I have a diagnosis of dementia. What does that actually mean? It means that the person has cognitive dysfunction that interferes with their daily activities, with, again, the most common form of dementia being Alzheimer's disease. So some other statistics from the Alzheimer's Association, 6 million individuals with Alzheimer's disease in the United States. It's projected that that number is unfortunately going to continue to grow. It's the 6th leading cause of death in the United States. 1 in 3 seniors dies with Alzheimer's disease or another form of dementia. And it's the only cause of death in the top 10 that cannot be prevented, cured, or slowed. So it is a real problem in the United States. So I just want to point out the timeline of the cascade of Alzheimer's disease. Alzheimer's disease is caused by the accumulation of amyloid and tau. So here are these red and these blue lines, and these proteins are naturally occurring in the brain. So what happens is we have amyloid that clumps together, that forms plaques that collects between the neurons and disrupts the cell function. And then we have tau molecules that form threads and eventually join to form tangles inside the neuron. So that's where you hear the term amyloid plaques and tau tangles. And this happens years before someone becomes symptomatic. So when we have a loss of neurons that happens in large numbers, we can see then changes on the MRI. So here's this changes on the structural MRI in yellow. And then we see the emergence of memory difficulty here in the purple. In individuals with mild cognitive impairment, or MCI, the stage between what is the expected cognitive decline of normal aging and that of a more serious decline in persons that we see in dementia, it involves persons with cognition that is, they're having more difficulty, again, than we'd expect for someone with age-related changes. So you have memory change that occurs, but with little functional loss. So it's often the preclinical stage prior to dementia, specifically Alzheimer's disease. So mild cognitive impairment, again, is a noticeable and measurable decline in cognitive abilities that is greater than what we would expect for age. Persons with mild cognitive impairment commonly have mild problems performing complex functional tasks that they used to be able to perform, things like paying bills, preparing a meal, or shopping at a store. They can take more time to perform these tasks. They are less efficient. They may make some errors at performing these activities, but nevertheless, they're generally able to maintain their independence in their function in their daily life with very minimal aids or assistance. Alzheimer's disease is a clear-cut worsening of cognition, either by self-report or oftentimes observation from a family member or friend. And it's insidious, meaning that the symptoms gradually progress over months or years. And the symptoms aren't generally seen in the course of over hours or days, like, for example, in delirium, where you see that type of presentation. The amnestic presentation is the most common syndromic presentation of Alzheimer's disease. These are deficits and impairment in learning and recall of recently learned information. So again, short-term memory deficits. There can also be difficulty with language, prominent deficits in word finding, for example. There can be visuospatial impairments as well. People get lost in familiar places. There can be difficulty with facial recognition. There can be executive impairment as well. The most prominent deficits include things like impaired reasoning, judgment, and problem-solving abilities. Things like handling complex tasks, such as balancing a checkbook, can become difficult. And the diagnosis is probable. And the reason that we say this is because we can't see the plaques and the tangles to diagnose Alzheimer's disease. until we see the brain directly at autopsy, for example. I want to also point out, and this is an older study, but it's an important seminal study because individuals with Alzheimer's disease and other forms of dementia, in addition to having cognitive difficulties, will also have behavioral symptoms or neuropsychiatric symptoms. We can see agitation, aggression, delusions, hallucinations, and wandering. And there are going to be quite a few patients that will also experience depression as well. And these neuropsychiatric symptoms are really the main reasons why patients are admitted to long-term care facilities, because these behavioral symptoms can be very difficult to treat. I'm going to talk a little bit about that later on. So an important question that people often come into clinic asking is what's going to happen. They want to know what to expect as the disease progresses. They also want to know about staging and what stage of the disease their loved one is in. And that's why I think this slide is important. In the mild stage, people generally have some difficulty with their activities of daily living. And so they may need some assistance, like prompting, for example, in the mild stage. Some behavioral changes that you can see in the mild stage, people can have some apathy, they can have some difficulty with motivation. There can be depression in the mild stage of Alzheimer's disease. It's also quite common. Anxiety is quite common in the mild stage of Alzheimer's disease. And then cognition, things we just talked about. There can be some confusion and memory loss, misplacing objects, disorientation in time, and impaired word finding. As the disease progresses in the moderate stage, people will become more dependent on their loved ones or other people for their activities of daily living. So at this point, they may need some help with getting their arms into their shirt or getting their shirt over their head. They may need some hands-on assistance with bathing at this point. Some behavioral changes that we see include anxiety. So individuals in the moderate stage may have difficulty interpreting their environment, and this can make them feel fairly anxious. So you can see anxiety, suspiciousness, pacing, and sometimes sleep can be disrupted also in the moderate stage. In the moderate stage, people can have difficulty recognizing their friends and family. There can be comprehension difficulty, and there's going to be more difficulty with planning out their day-to-day activities. In the severe stage, unfortunately, we see total dependence on other people for their activities of daily living. And behaviorally, oftentimes we see individuals can develop agitation and wandering. There can be difficulty and a total loss of speech, dependence on others for communication. And this is where in the severe stage, you can see difficulty with that long-term memory. Other common causes of dementia that I want to point out include vascular dementia, Lewy body disease, frontotemporal degeneration, and then quite commonly we see mixed forms of Alzheimer's disease and vascular dementia. So vascular dementia, the second most common form of dementia that is also called multi-infarct dementia or small vessel ischemic disease due to strokes or mini strokes that can occur suddenly if you have a large stroke or progress over time stepwise decline if you have an accumulation of mini strokes. On neuroimaging, on MRI, for example, you can see evidence of vascular lesions. And the symptoms really depend on the areas that are affected by the strokes, but we can often see, particularly in people who have small vessel ischemic disease, problems with executive function. So they have problems with organization and solving complex problems, slowed thinking, distraction. And again, if you have a stroke, you can see some focal motor signs on your neurological exam. Individuals with Lewy body disease have both cognitive and motor features. And so here are the criteria. Here we have fluctuating cognition with pronounced variations in attention and alertness. So we have fluctuating cognition. There can be visual hallucinations. Oftentimes these visual hallucinations aren't threatening to the patient. There's REM sleep behavior disorder. And then we have one feature of Parkinsonism, one or more feature of Parkinsonism, either bradykinesia, so slowed movement, you can see a rest tremor, or folks have rigidity. I want to point out too here that other Other symptoms that can occur commonly in people with Lewy body disease, there can be sensitivity to antipsychotic agents. So that's important to think about. If you are using antipsychotics to treat visual hallucinations, you have to be careful because there is a sensitivity to antipsychotics. There can be postural instability, repeated falls, and orthostatic hypotension, constipation are also common in Lewy body disease. Frontotemporal degeneration, or FTD, because it's a mouthful to say, is a common cause of young onset dementia, meaning that individuals with FTD, their symptoms often begin before the age of 65. And just as the name states, frontotemporal degeneration, the disease affects the frontal and the temporal lobes of the brain. From my first slide, you know that the frontal lobe of the brain is important for personality, and the temporal lobes of the brain are important for speech and language. So there are two major phenotypes. One is a disorder of social comportment and executive function called behavioral variant frontotemporal degeneration, where individuals with BVFTD present with prominent changes in their personality, things like severe apathy, disinhibition, compulsive behaviors are common in BVFTD. The second major phenotype of frontotemporal degeneration is something called primary progressive aphasia. And from there are two variants. One is called non-fluent variant primary progressive aphasia, where there is slowed speech. And there's a semantic variant primary progressive aphasia, where there's difficulty with object knowledge. So I want to talk a little bit more about the assessment of dementia. It always begins, importantly, with an interview with the patient and the caregiver. The patients with dementia can sometimes have difficulty with their insight. So I just want to emphasize that it's important that you often have a caregiver or someone who knows the patient when you're performing your assessment to really get a good history. Importantly, you want to ask about how things are going functionally. Remember, because that's how you discern someone between mild cognitive impairment whose functional status is relatively preserved compared to someone who has a true dementia where there is impairment in daily activities. A neurological exam, right? So where you can find focal motor symptoms in people like Lewy body disease and in vascular dementia. A cognitive exam, neuroimaging, and we're going to talk about what types of neuroimaging should be ordered. A neuropsychological evaluation is often helpful by a neuropsychologist. And then lastly, the diagnosis of dementia is really a diagnosis of exclusion. And we'll talk about some of the laboratory tests that you can get to rule out things like a B12 deficiency or a problem with the thyroid. So just some pointers important to think about when you're seeing, especially older adults in your practice. Make sure that their hearing and their vision aids are in place before you start some cognitive testing or before you start the interview. Again, emphasizing the importance of obtaining proxy reports. There's certainly some great instruments out there, but using them cautiously. And then oftentimes the exam needs to be repeated to see if things are progressing over time. Remember, if this is truly a neurodegenerative disease, then things are going to get worse over time. And so it's really important to bring the patient back over time to see if there's worsening. So I like to use the 88 to guide my history taking. So asking about problems with judgment, has there been a reduced interest in hobbies? So really getting at if there's any apathy present. Does the patient repeat themselves during the course of a conversation? Do they ask the same questions over and over again? Is there any visuospatial praxis, difficulty with praxis, using a tool or appliance? This is asking about, do they often forget the month or the year? Is there difficulty with managing bills or checkbooks? Difficulty remembering appointments? Or again, difficulty with their memory? Can they recall what they had for breakfast, even with the provision of cues? The physical examination, again, you're going to do the physical to really rule out an atypical presentation of a medical illness like congestive heart failure, for example. You want to do a complete neurological exam. And as I mentioned, you can have some focal neurological findings in people who have vascular dementia and Lewy body disease. but generally you're going to have a normal neurological exam in individuals with Alzheimer's disease. So the various components of a mental status exam include the physical appearance and behavior, affect, level of consciousness, memory, language, analogies, abstract reasoning, calculations, drawing, judgment, mood, thought processes, and perceptual distortions. And this is a fairly comprehensive list. And I think that that's why, sometimes it's helpful to have, a neuropsychological exam to, order a neuropsychological exam for your patients, because this can be a pretty extensive visit. So just briefly, the mini mental state exam, or the MMSE, is probably the most commonly used tool to screen individuals for cognitive impairment. Again, I just want to reiterate that this is a screening tool and is not a diagnostic tool, but is important for screening individuals for cognitive impairment. Certainly performing an MMSE does not allow you to discern which type of dementia someone has, but again, it's just important for screening for cognitive impairment. But it includes components like memory, where you assess orientation, and you ask the person to remember 3 words, and then you delay for about a minute or so, and then you have them repeat those words back. You say, what were those words that I just asked you to remember? For language, you have them name. Oftentimes, in clinic, will ask them to name a pen or a pencil, whatever I have in my hand, and then I hold up my watch. You have them read a sentence, write a sentence, and then repeat, no ifs, ands, or buts. To assess visual spatial functioning, you have them copy intersecting pentagons. And then for attention and executive function, spell world backwards. And you give them a 3-step command. Generally, take this piece of paper into your right hand, fold it in half, and then place it on your lap. The MoCA, the Montreal Cognitive Assessment, is another screening tool that includes cognitive domains such as concentration, attention, memory, visual constructual skills, calculation, executive function, and orientation. And so this can be another helpful screening tool to use in your practice to screen somebody quickly for cognitive impairment. Clock drawing is another commonly used screening tool, which tests executive function, planning, reasoning, and spatial abilities. So you ask the patient to draw a clock. Generally, you don't say, draw a clock and show me 12 o'clock. You make it slightly challenging for the patient. You can have them show the time at 8:40. In this next picture, you see that you are asking the patient to show them 10 past 11. And you can see that, again, based on the different stages of dementia, how the clock drawing looks as the disease progresses. The Mini-Cog is another screening tool that can be used. You do a 3-item recall for memory and then also incorporate the clock draw. The scoring for this is 1 point for each recalled word. The clock draw is scored as either normal or abnormal. And then you can see the point system here. So if they can't recall any of those 3 words, then that is considered concerning for cognitive impairment. If they can recall 1 to 2 words, but then they have an abnormal clock draw, then again, considered concerning for cognitive impairment. If they can remember 1 or 2 words and then they have a normal clock draw, then that's considered negative. And if they can remember all 3 words, then that's generally a negative screen. So again, just a couple more thoughts about memory. I just want to go into each of the cognitive domains now and talk in a little bit more detail about the different cognitive domains. So memory, we can think of as immediate, which lasts only a few minutes. So an example of assessing immediate memory would be digit recall. So giving someone a span of, say, 5 numbers, 7, 5, 4, 2, 3, and then having them repeat that back. That's an example of immediate memory. Short-term memory, things that I just asked you to do, again, have them repeat apple, table, penny. You want to delay for a couple of minutes or even 5 to 10 minutes, and then ask them for those words back. They should be able to repeat apple, table, penny after that amount of time. And then remote memory, asking about significant personal events. Speech and language, so fluent speech generates about 40 words per minute, and it's generally grammatically intact and not effortful. Pressured speech is a tendency to speak rapidly and frenzied by an urgency, and it's sometimes difficult to interpret and can be tangential, so they can move from subject to subject without making the connection between the subjects of the sentences. Repetition is important to evaluate as well. So again, we evaluate that in the MMSE by saying, repeat for me, no ifs, ands, or buts. Comprehension, naming of objects. Again, in the MMSE, you ask them to name a pen or a pencil and name a watch. And then comprehension can also be evaluated by asking them to point to simple objects in the room. So I often ask my patients to point to the ceiling and point to the floor. We've talked a lot about executive function. I like this cartoon, first your pants, right? First you have to put your pants on, then you have to put your shoes on. So sequencing, right? Again, executive function is a higher order cognitive function, planning and organizing, being strategic and multitasking. One way to evaluate executive function that's commonly used is something called letter guided fluency, where you ask an individual to give you all of the words that they can think of that begin with the letter F. You ask them to give you things that, so no proper names and no numbers. So it's really kind of a mental search strategy. And they should generally be able to give you about 11 words or so within a minute. Analogies and abstract reasoning. So analogies is higher order abstract thinking, involves the discovery of relationships in a pair of abstract figures and the recognition of similar conceptual relationships. So how are an orange and an apple alike? How are a poem and a novel alike? And then proverb interpretation. So what does it mean when you say people who live in glass houses shouldn't throw bricks? Well, a concrete response might be, well, he might break something. Calculation, so we can ask people to start at 100 and subtract 7. So that's what we mean by serial sevens. And they should do that subsequently. I tend to have my patients do this about 5 times, so subtract 7 from each number. It can be quite difficult and is certainly affected by education, so keep that in mind. Ask individuals to give you the days of the week backwards, or again, in the MMSE, we have folks spell world backwards. Visual spatial functioning, again, a good example of this is in the MMSE is copying those intersecting pentagons. So in this, you're having to see a figure. You have to be able to combine visual information and motor coordination in order to duplicate and understand the spatial relationships of these objects. And then behavior is really the last cognitive domain that I think is really important for us to pay attention to. So does the patient come in and how do they behave? Are they socially appropriate? Are they following social cues in the clinic setting? Are they apathetic? Or is there a flattening of the affect? Are they agitated? Are they irritable? Are they anxious? So these are all important behavioral symptoms that are important that should be part of the cognitive exam. So the laboratory evaluation, really depends on the HPI and on the patient's past medical history. So the primary purpose, as I've stated previously, is really to rule out any potential reversible cause for cognitive impairment, and also to investigate for any comorbid medical illness that could be causing a mild delirium or temporary worsening of cognition. So some common laboratory tests that we'll order: complete metabolic panel, CBC, B12 level, TSH, Lyme, HIV testing, ANA, ESR, and CRP, right? These are for autoimmune and inflammatory conditions. And then in some cases, a lumbar puncture can be useful. In terms of the neuroimaging, structural imaging and MRI of the brain is preferred over a head CT, for example. And if the MRI of the brain, oftentimes in specialty settings like dementia clinics, will get PET scans. But generally at the primary care level, an MRI of the brain is the preferred imaging modality. So I want to turn now to talk briefly about what the current therapy is for folks with Alzheimer's disease. We have cholinergic supplementation and other symptomatic treatments. I'll talk about a medication called Memantine. There's etiologic therapies, and the one that has probably received the most notoriety recently is aducanumab or Aduhelm, which is an amyloid antibody agent. Not too long ago, actually June 2021, the FDA approved the drug aducanumab for the treatment of Alzheimer's disease through their FDA Fast Track program. So the approval was really monumental, but somewhat controversial because studies show that aducanumab doesn't stop or reverse the disease, but may slow progression of Alzheimer's disease. And so the accelerated approval pathway requires that the drug company now verify the clinical benefit in a post-approval trial, which is currently ongoing. So the medications that are, again, are currently FDA approved are the cholinesterase inhibitors. We use cholinesterase inhibitors to increase cholinergic transmission by inhibiting its breakdown by cholinesterase. So to date, there's been no head-to-head comparisons of cholinesterase inhibitors, and the main differences in the agents are really in the side effect profiles and the ease of administration. So for example, donepezil is once a day dosing, where galantamine may be once or twice a day dosing. Other medications can come in the forms of a patch and can be useful for patients who don't tolerate pills. So again, these medications are currently approved for mild to moderate Alzheimer's disease. Common side effects include diarrhea, reduced appetite, muscle cramps, and bradycardia. So it's important to keep in mind. And if your patient has a history of slowed heart rate, or you have concerns that they're about bradycardia, you may want to check an EKG before you begin these therapies. Another medication approved for moderate to severe Alzheimer's disease is a medication called Memantine, which is really neuroprotective by inhibiting excessive glutamate, which is an excitatory neurotransmitter that can further damage the nerve cells. And so Memantine is, again, approved, the other medication that is approved for moderate to severe Alzheimer's disease. So generally, you're starting the cholinesterase inhibitors first for individuals in the mild stage of Alzheimer's disease. And then when individuals become moderately impaired, you're then adding on Memantine to their drug regimen. I mentioned earlier that behavioral symptoms are exceedingly common in individuals who have dementia. So oftentimes you can see depression and apathy in the mild stage. And so oftentimes you may be starting SSRIs for your patients who have problems with depression in the mild stage of disease. And the moderate stage of disease, again, we can see things like agitation, delusions, sleep disturbances. And so using medications like SSRIs, again, can be helpful for individuals with agitation or severe anxiety in the moderate stage. I always caution sometimes atypical antipsychotics are warranted when individuals become severely agitated or when there's a safety concern, but be very careful with atypical antipsychotics, because there is an elevated overall mortality rate and an elevated risk of sudden cardiac death related to prolonged QT syndrome. So always use these very conservatively, start low and go slow. Non-pharmacological interventions are really the first line. I'm going to talk about those on the next slide. So non-pharmacological interventions that are important to consider and to also really educate friends and family about are providing things like reorienting the patient, providing reminders and cues. The environment, as I mentioned, can sometimes be overwhelming for people who have dementia. They can have a hard time processing and understanding the environment. So thinking about how the environment can affect the patient's mood is really important. So think about keeping the noise level to a minimum, putting familiar objects around the rooms, using pictures as cues. For example, the bathroom may become a problem, especially in the later stage of Alzheimer's disease. So using like a picture of a toilet and putting a picture of a toilet on the bathroom door so that the patient knows where to go can sometimes be helpful. Patients with dementia do really well from a routine where they can know what to expect every day when they wake up. So it's really important to develop a routine of activities every day, again, to know what to expect, and also to reduce boredom, reduce complexity of the activities. So again, breaking down activities can be really important. So things like making a sandwich, that's a pretty complex activity. So things like laying out the bread and the peanut butter and jelly for the patient, and just taking them through one step at a time in making a sandwich can be helpful. Using simplified language, we speak very fast, we use lots of sentence fillers. So speaking in a simplified way, speaking in context. If you're having a conversation about what you're going to have for dinner, perhaps having that conversation in the kitchen and giving the patient two choices. Are we having pasta? Are we having a sandwich? And again, showing pictures of what the choices are. People with severe dementia can still understand facial expressions. They appreciate eye contact and they can still appreciate smiling. So think about all these things, especially when you're communicating with individuals who have who are in the later stages of dementia. As clinicians, it's important to think about driving and when it can become a really difficult decision about when to have that conversation about the risk of driving with individuals who have cognitive impairment. So here are the American Academy of Neurology guidelines, which were reaffirmed in January of 2022. The risk factors: a history of citation, if your patient have a history of crashes, if they start driving less, there's situational avoidance, if there's problems with behavior like aggression or impulsivity, if the mini-mental score is less than 24, or if there's alcohol, sleep disorder, visual impairment, or motor impairment. These are all important risk factors and things for you to think about as a clinician, where you might want to encourage family support for alternative transportation. Perhaps you might want to encourage a cognitive driver's evaluation, or for people where there's clearly a very strong risk for driving, asking the patient to surrender their privileges. General principles of care for people who have dementia. So again, safety concerns become a problem, especially as the disease progresses. The Alzheimer's Association is a great resource. They have a safe return program, so advising your patients to look into that. We talked about a driver's evaluation and thinking about environmental modifications in the home. Things like, again, putting up pictures on doors to provide cues for locations of things like the bathroom. Structure the living environment to maximize their abilities. Monitor for general health. So confusion is often the first sign of a health problem. And again, here I'm alluding to delirium. So individuals with Alzheimer's disease and other forms of dementia really are at higher risk for developing delirium, especially in the later stages of the disease. And oftentimes there is an acute change or an acute confusion that could be the sign of an underlying health problem like a urinary tract infection, which is what we see commonly. It's important to think about advanced care planning early on when the patient still has the capacity to describe their wishes for things like CPR and for things like whether to pursue feeding tubes, those types of things. So it's important to have conversations about disease progression, disease trajectory, and advanced care planning early on. Our social workers in the at University of Pennsylvania are really key, and it's oftentimes important to include the whole family in these conversations. And then educating the caregivers about resources, long-term planning, and thinking about respite care. So it's important when you're caring for someone with dementia to not only care for that individual patient, but also that care then becomes extended to the caregiver as well. So assessing their caregiving skills. Oftentimes I spend much of my clinic sessions educating about disease symptoms and again, what to expect as the disease progresses. Providing important information on resources. So things like the Alzheimer's Association, the Association for Frontotemporal Degeneration, area agencies for aging, and the Lewy Body Association are all really terrific resources. Caregivers are often incredibly stressed. And so asking the caregivers how they're doing with managing their loved one's care is really important to ask at every visit. And then talking about respite care. And so respite care is a short time of rest or relief and can be done through a variety of ways. Things like journaling, seeking professional help through a therapist or a counselor, having a buddy system. Adult day programs are often good for, again, getting a short break during the day. Professional caregivers, so having companions coming to the home, or short-term stays in a nursing home or assisted living, depending on how much the patient needs are. I often get asked the question about when to refer a patient to a specialty center, like a cognitive neurology clinic. Oftentimes when there's an atypical presentation of dementia, when the patient is young. So again, when there's that young onset dementia, when there's a significant psychiatric comorbidity, of course, when it's requested by the family or the patient, or when the patient and the family are interested in participating in research. And my last slide, just showing you a couple of different resources here that I find that are particularly helpful for patients and families. Again, area agency, your local area agency for aging, Alzheimer's Association, Alzheimer's Disease Education and Referral Center, the Association for Frontotemporal Degeneration, and the Lewy Body Association. These are all really terrific resources for individuals and are disease specific. So with that, I thank you for your attention and have a good day.